And welcome to all those coming in. Thank you all for joining today. So my name is Sarah Grant. I am one of the health education and resource development officers for Black Beetle Health. And today I am joined by Lisa Graham, my mentor. She's going to further introduce herself and tell you a little bit about her journey moving into the space where she is right now. As you may know already from previous events that we've had, my area, my portion of Black Beetle Health focuses more so on the chronic disease management area. But of course, Black Beetle Health as a whole is interested and invested in the education and empowerment of those in disadvantaged communities across the UK, particularly those in the BAME community as well as the LGBT community. So, but of course, these topics are applicable across the board and even across the pond as well. So Miss Lisa is actually located in the Atlanta, Georgia area. So she is going to first introduce herself and just let us know kind of how you started as far as your career goes and how you transitioned to where you are now.
Okay. Well, thank you, Sarah. I'm so happy to be here. And you two, one of my, of course, favorite people, and just so happy that our paths cross. And as she said, I am Lisa Graham. I am a registered nurse and a certified diabetes educator. I've been a nurse over, oh my gosh, 27 years. That, of course, dates myself, but a very, very long time. And in this diabetes arena for the past 17. I worked, of course, as a traditional nurse for most, of course, of my career. And in 2016, after leading one of the larger health organizations, diabetes department, I was coordinator of that department. I ran 3 locations, managed inpatient and outpatient. I really saw that, of course, there was a different way to do what I did every day. And I think what pushed me, of course, in the direction or to where I am now is because I kept seeing these numbers, of course, in diabetes cases continue to rise. And I knew that we were doing everything that we could do on our part, but we needed, like I said, to do things a little bit, of course, differently. So in 2016, I walked away from my position at the hospital to start my for-profit company called Renew and Live. And the goal of that was really to bring education to communities, to physician groups, organizations, and to work with them in where people were, because that was a lot of the comments that we were getting from individuals that, of course, came to see us at the hospital. Cost was an issue for some, the location, the time of the classes. Did we have these classes at any other time? Of course, people not being able to take off of work. And we also had physician groups, of course, reaching out to us and asking if we could do something in their offices. As we know, people are creatures of habits. They like their space, and being in that space. So I'm familiar with the physician's office. I'm familiar with this group. I'm familiar. And what I wanted to do is bring the education, of course, to those spaces. And so I did that. And after about a year of that, I was I'm a very spiritual person, what I say to everyone, and I was being pulled. I had actually got that call a little bit sooner, but I was like, how can I do this and do this for-profit company at the same time? But about a year later, in 2017, I launched Diabetes You Can Win. And Diabetes You Can Win is a nonprofit organization, a 501(c)(3) organization. And this was something, again, I did not think that I would do with leaving, of course, and coming into this space. But I had worked for many years with many nonprofits here, of course, in Atlanta, which do an outstanding job. But what I felt was lacking was basically that we needed boots on the ground, and we needed people in communities, and Diabetes You Can Win serves those communities, underserved, uninsured, underinsured, those communities, and providing diabetes education. And what I felt we needed to do is truly bring clinicians to the space. Again, we have wonderful community health workers, lay personnel that come to these communities, but oftentimes for us to really see and be able to change some outcomes in these communities, we need clinical staff. And that means that we need people who are going to be able to address their individual needs in regards to diet and medication, and really be able to give them a plan, which that doesn't sometimes happen. And so that was the launch of Diabetes You Can Win. And that name came about because I do believe we're losing this fight with diabetes, but I believe it's a fight that we can win, and we can do that, of course, through education. So that's how, of course, Sarah and I met with some of those community events that we do. And I just wanted to stop there, Sarah, to give you, I don't know how much further you'd like me to talk about that.
That's
I want to
great.
give you an opportunity to
Yeah,
speak.
and the great thing is that, you know, the missions of these organizations overlap and coincide so well, because it's about finding that gap and working on filling it,
Yes.
as a very, you know, sometimes independent organization, and then building those connections as we go along. So
Yes.
I think that's really great, because, you know, something that is always so shocking to me is that diabetes is talked about so much, like
Yes.
across the
Yes.
globe. There
Yes.
are organizations, there is funding out there. It seems like there's so much new technology that's coming available, and it's just like, but the numbers are still increasing
Yes.
steadily.
Yes.
The
Yes.
number of people who are at risk of
Mhm.
developing diabetes is still increasing. So that shows that there is something
Mhm.
there that needs to be filled, a gap that needs to be filled, and especially when we go into some of the more underserved population. So I
Yes.
do want, that's my next question for you actually, is how did you decide to focus on certain populations, or what populations, I should say, do you focus on, and why?
Well, I think that, again, across the board, the main focus, of course, are underserved. And like I said, the uninsured. And unfortunately, you know, of course, people of color fall into that range. But we do know there's a wide range of people that also, of course, are challenged, of course, in those areas. But it
Mhm.
does seem to be, like I said, the people of color. And what I found, like I said, as you just said, we have tons of organizations, but I really believe that it's the boots on the ground. We have to, of course, truly get into these communities and connect, of course, with the communities. So when you look at it, I know you're going to talk in regards to a little bit in regards to statistics. And although even over these years we had recent statistics that came out, we still see, of course, people of color lagging behind, where, of course, when you look at Caucasian or white individuals that may be doing a little bit better in regards to, of course, that, you know, diabetes prevention, of course, is management and all of that. So that was where me seeing that those numbers, like I said, continue to increase in that population, that I really wanted to focus, of course, in that area. And what I truly believe, and where we have, like you said, diabetes is a pandemic. We're dealing with a pandemic. Diabetes is a pandemic. As we can having this conversation, of course, across the waters.
Mm.
But what I think, again, is lacking, and when I talk to people in these communities, is the education. I deal with people who have had diabetes over 10 years and never had education. The small amount of education, the doctor said don't eat carbs, or they
Right.
said stay away from sugar. You know, I just had this week, a woman called me and said that they called her and said that she had that. And then they said, go find a Weight Watchers diet and follow that. So what I find in this, of course, these communities, lack of education. Many of them may not have health care, may not have someone that they go to on a regular, of course, basis. And so they do not have, again, that access to, as we've talked about, and this has, of course, become a global, of course, discussion, but they don't even have access to the information. And when they do have access to care, nobody's telling them, of course, about the information. So one of the things, again, is being able to be there and be those boots on the ground and talk to those individuals that this is something we can do something about. Because that's another thing. When you have these communities that are affected by, of course, and I just say diabetes, because it can be chronic disease as a whole, they've had family members that have dealt with this. So a lot of times they just feel it's inevitable. This is what's going to happen. This is what's going to be. And I really can do nothing about it. So being able to be there and give them hope and let them know that this is something that you can do something about. And this is something that you can prevent. And this is something that you do not have to die from.
Right. So you mentioned the pandemic, and it's like, you know, the questions I'm going to ask. The next question that I wanted to hear more from you is, well, I guess we didn't go into much detail about specifically what services you offer, but I know that you do have the education for individuals with diabetes, and then you also have education and services for individuals who are at risk of diabetes. And so, you've already been doing that in a mobile type of way. You go to them, you offer them in collaboration with different health departments and places so that it's more accessible for individuals. But then with the pandemic and concerns about social distancing and things, you had to take that to a whole new level. So please tell us how you were able to do that, even when other organizations had to pause or go on hold.
Yes. And you're correct, Sarah. So our work, of course, in the community last year, we did over 60 events, live events in the community where we screened for, of course, blood sugar as well as blood pressure. We did live educational classes. We did live support groups. You know, and wherever we were, churches, community centers, wherever we were, and all of that, and we did at no cost, of course, for the community. As you said, when the pandemic hit, I was just, you know, I had to take a moment, as I think most of us, of course, did. On the for-profit side, I had contracts in place, and although those changed, they were still, of course, in place. But on the nonprofit side, everything we did from diabetes was in the community. So that was where, you know, from our seniors to young people, that everyone said we're shutting down. And my was, you know, I guess it was, my heart was so heavy because I was like, how do we reach, of course, these individuals? And as I said, after I took a minute and kind of, you know, came up, of course, for air, I said, we have to figure out how we are still able to touch, of course, this community. And I thank you, of course, Sarah. And, you know, we brought some wonderful interns in on the, into the organization, and really started to, you know, I, of course, had some ideas, and then, you know, you all, of course, they're working with, of course, and helping us in the organization. And we thought we have to pivot. And what we, of course, developed at that time, because although we couldn't come together, we still knew people were out there in need, and especially this population, because as we already know that there was the need there, now it's even greater because we can't get to people. You know, I often said there's so much focus on the COVID, which it does need to be there, but we have these people in communities with these chronic diseases that are not having their needs met, fear of going to the hospital, not having, of course, like I said, those physicians and things in place. So what we did is, like many others, we went virtual. So we were able to, of course, now offer classes, our diabetes prevention classes, our diabetes prevention program, which is the CDC program. them. And one of the things that I'm so excited about, and of course with Sarah, I just thank you, of course, and your team, of course, with working on is our support groups. And this, of course, more than any other time is needed because of the isolation. And like I said, isolation in the population, but even greater isolation in these communities. And for them to be able to connect, of course, in this group. I was on a call before this one, and I'm doing a nutrition series with another group. And one of the ladies was like, well, I just came because, you know, just being at home and just, I'm just bored. I'm just tired of being by myself. I wanted to connect with people. So I'm very excited about the support groups. And we are looking also to hopefully get some walking groups and things, but we went virtual. We've done one event, which was actually a Juneteenth event that we were asked to come out to. We put on our masks and gloves and we were there. There's just not, of course, a lot, but I'm excited about the team that they are willing to go out if we have to, but we're trying to be safe and keep other people safe. But moving to that virtual, which challenges, of course, there.
I
But
was
I
going to
was
say,
excited.
because
Yes,
everybody
yes,
doesn't have internet access.
yes, yes,
People may not be as comfortable with computers in certain age
yes.
groups, in certain communities as well. So, you know.
Exactly. And again, my group this morning were challenged the last 3 days of trying to get them connected. And many of them were connected, but many were not. But we were also, Sarah, I just want to add that we were also able to bring classes virtually to individuals that speak Spanish. And many of them, of course, not having any insurance. And a lot of the people we've encountered do not have any insurance.
And the interesting thing is that in the UK, the National Health Service offers coverage for all citizens and many residents as well. So they don't necessarily have that challenge, but the challenge might be the wait time to get in with their general practitioner. So sometimes people might have symptoms, they might feel things, they're not sure, but if it takes months maybe to even get an appointment with the GP, that can delay and extend their treatment, getting into treatment. And then something else that I kind of want to transition to has to do with the comfortability, some of those other issues that are surrounding the health access. So while seeing the provider may be accessible, if people have maybe reservations about, they may not trust the provider, they may not feel, depending on their status or whatever the case is, if they may feel apprehensive about seeing the provider and disclosing certain things, it also causes them to possibly delay getting that treatment until it's, you know, more severe. So I'd love to hear some of kind of like a couple of your success stories of individuals who have previously been in more traditional settings as far as their healthcare, but now they've been able to join into your programs and add on that piece and how they've been doing with that.
Yes, and I definitely agree with you there, because we know that, of course, in these communities of color, there is somewhat of a distrust, and that definitely here in America, and that's based on, you know, what has happened, of course, over the years and you know, in these communities. So like you're saying, making sure that they feel, of course, comfortable. And when you think about, when I think about, of course, of stories, again, so many, of course, different ones, but as just thinking about that question, I remember one of the ladies, and she was of course a senior, and one of the things that she was saying, she actually came to my diabetes class, and she was not, you know, kind of, you know, through a couple of people kind of learned about it and came on in. And one of the things that I remember her saying to me is that if I did not have diabetes, I would not have received this information. And she said, this information is so important. This information needs to be shared with everyone. And
Right.
she said, I think about that, you know, when she just think about her family and her grandchildren and so on and so forth. And she said, had, you know, I not had this information, now me being able to go back and, of course, share this. And that's one of the things I say to them often is that, you know, take this information and make sure that you share it. I talked to them about being ambassadors.
Mm.
And that, in a sense, when I heard that from her, it really, I've always known how important, of course, education was, but it really said to me that through education, we can, of course, education as a whole, but health education, that we can, affect generations.
Yes.
So that this one person, and this is of course a senior, but a young person that gets the education and being able to pass that down. And I think about the day that of course it all comes, that I won't be here, but what I've learned and what I've shared, that it will affect, of course, generations. And that's something I think, Morrison, that's so powerful in regards to just what we do, of course, in this health education, of course, arena. And I can't just talk about countless, of course, times of people who came in and really thought that there was no hope, and really just thought that they had to take medications for the rest of their lives, or thought that they had to be on insulin for the rest of their lives. And through, again, the education and learning how to, of course, change their diet, increase, of course, their exercise, and that the power was in them. Because oftentimes people call me and say, oh my gosh, my numbers have dropped. This is what I've done. Thank you so much. If it wouldn't have been for you. And I said, I, of course, was the catalyst, but you did all the work. You had to make sure that you out there exercise, that you watch what you put in your mouth. So I'm so excited to be on that journey and being able to be there for the individuals, but it's them. And I always want them to know that it's them that really, of course, helped or got them to, of course, be successful.
That's true, because you may only see them for 4 weeks, once a week,
Exactly.
maybe something
Exactly.
like that. And then of course the actual GP even
Yes.
more less frequently. So
Yes.
it really
Yes.
depends on what they do in between those visits. So yeah,
Absolutely. And one just
and
thing I just wanted to add, because, when you said that, it made me think of something. I say to them all the time is that, you are with, me, like you said, the 4 weeks, or you with your physician a couple of times, but you with yourself every single day. So
mhm.
again, it's what you're doing every single day. So that's such a good point.
Right. And I remember you told me a story about a lady in the past few months that was in your program and saw a dramatic drop in her A1C. Can you share that story?
Yes, yes, yes. So, and that was, again, it was, very unique, because as her and I started to talk, we realized in my voice, because we can't see each other. And she says, I think that you worked at my school. And it turned out my children went to the school, of course, and she was a very
Oh,
professional
oh,
there.
wow.
But she came in and she was very, uh, just very down about the fact, of course, number one, with diabetes. She was admitted to the hospital. Most people are not. They go into the doctor and they get, of course, this information, but she was actually admitted. And
Hmm.
she had an A1C, I think it was maybe 14, which really puts her probably around three, high threes, fours, somewhere in there, in regards to her blood sugars, what was going on at that time. And so that was back in May. And when her and I spoke, she was just saying that I want to get off this medication, decrease this medication. I really know nothing, of course, about, of course, eating and what to do. And she came through my 4 week, of course, program. And coming out of the program, she praised, of course, with, the information that she received. And she said, I'm just going to tell everybody about it, which, of course, we love, because the more people we can educate is always great.
Hmm.
And so she texted me actually just this past week, and I was going into another prevention class that same morning when she texted me, and
Hmm.
she said, I just, again, that story of in May I was at 14. She said, I just came back, and this is, like I said, just at the end here of August, and came back and I have dropped to a 5.8.
Wow.
So that is tremendous. And although she, like I said, is on, of course, medication, but during our time together, she had to start decreasing the amount of medication that she was taking just in that 4 week period, because her
Yeah.
numbers start dropping, of course, so low.
Right.
And just with that, we look at medication and we know that there's, of course, a slight difference when we talk about A1C, sometimes 1 to 2 points. But when you
Mhm.
have, oh my gosh, I can't even, that's over 9 points or whatever, do the quick math. But to have that, how much she had to do to get
Yeah.
herself, of course,
Right.
there. And so, like I said, I just get so excited every time because again, the power of what they can do with taking charge, of course, of their health.
And I know that in the UK they mainly use the millimoles. So I was trying to make sure I
Oh,
have that
okay.
that comparison. But anyway, we'll
Yes.
come back to that. But
Hmm.
that's an excellent testimony, and being able to build those relationships, because I think we start developing that terminology, and even as I have worked with your organization and just grown in my diabetes education
Hmm.
um, skill set, I've learned that relationship factor is so key
Yes.
in helping people to feel to not beat themselves up, to
Yes.
think about things as, okay, you had a setback, but let's
Hmm.
reset. How can we do this better? Like you
Hmm.
said, sometimes the doctor will just say, don't eat carbs. And it's like,
Hmm.
well, what are carbs?
Yeah.
Can I eat them? And, like just starting from scratch and say,
Hmm.
because I know that when you educate, you're about having a well-balanced diet.
Yes.
And that's something really helpful. And then you also talk about the cultural application. So, okay, whether you're whatever part of the diaspora you may be from, you may eat a certain way, or if you're from Hispanic cultures or something like that, you have certain cultural foods that are part of your culture. And
Yes.
when somebody just says, don't eat this anymore, it's a shock. And you start feeling like,
Absolutely.
okay, well, I'm going to offend such and such if when I go to
Hmm.
their house and I don't have this thing or whatever it is. And so
Hmm.
I think it's really good to be able to put all of that in the context of the individual's
Yeah.
cultural experience and things like that.
Absolutely. Absolutely. And it's so funny that you say that. I was speaking with another patient last week, and he actually was, of course, South Asian. And he was, we were going through information about his diet. And I said, well, tell me a little bit about what you're eating. And he said, well, I'm having tortilla chapati. I said, are you having chapati or roti? Oh, he was just so excited. He said, you know
That you knew
chapati?
what he said. Oh, that's so
And I
nice.
was like, yes, I do. And, and
That's
and
so
like to your
nice.
point, it's important. And I'm not saying I know everything about that diet. I know everything about the Spanish diet. I am,
Mhm.
of course, African American Black, so that's the diet I know more than any other, of course, diet.
Yes.
But I do, like you said, it's so important to meet people where they are. So to
Mhm.
say these traditional things that I eat that I never can have again, to be able to say some things we are just have to take out because we just can't do them. But many
Yeah.
things we can incorporate, of course, into their diet because it is
Mhm.
something, like I say to them all the time, it's something that we have to do for a lifetime. We're not really on a diet. I call, of
Right.
course, my plans life plans, but not meal
Mhm.
plans, because really it's what we are going to do forever. And
Mhm.
especially if my goal is trying to decrease my risk of, of course, getting, of course, particular diseases, managing, of course, those diseases, we have to do that. But to your point, it's so important to be able to connect with people, of course, on that level and in their comfort of zone.
Yes. So I do want to kind of touch on some of the uh, kind of take a broader look at it,
Mm-hmm.
and talk about how these things apply on a bigger scale, because of
Mm-hmm.
course diabetes is one, but the unique or the interesting thing about diabetes is that it's connected to so many other conditions. Like, we never
Absolutely.
just talk about blood sugar when we talk about
Yes.
diabetes. We
Yes.
always have to look at the cholesterol. We're always going to
Yes.
look at the blood pressure, the history of heart disease or heart conditions and things like that. So it's interesting how a lot of the same issues are seen across the board and even
Mm-hmm.
globally. So can
Yes.
you talk about what you've seen, or just your opinion or your experience as a whole, in how the healthcare system is doing with managing chronic conditions as a whole.
I think that, of course, when we talk about this particular, of course, population, as we know, and I think it's been evidence that we see that there is a problem.
Hmm.
I think that we definitely do a lot, and you said something earlier, and what I say oftentimes, we put a lot of PSAs out. So there's a lot of information out in regards to what we should be doing, what's happening. These are the things, and these are what should happen. But in reality, we even have people that have insurance that don't go and of course get exams, don't go and of course get, of course, checkups and things that they need to do, and that's for various of course reasons. So I do believe that there are efforts being put forth to kind of make these things a priority, but I still look at and wanting to focus, of course, on this, this underserved population, is that we need, of course, again, the boots on the ground and people in these communities to have these individual, of course, discussions, because the numbers that we see, the numbers, of course, that continue to rise in, like you said, across the board, heart disease, of course, diabetes, kidney, of course, disease, all of these different things. And I don't want to say that, of course, medication is not important, but we have to focus on prevention. We have to
Right.
put money into prevention.
Mhm.
And I know this may not be, of course, very politically correct to say,
Popular, exactly. It's not the popular
but
thing. It's not,
but
but
at the end of the day, you know keeping people healthy doesn't make, of course, money. Keeping people sick, unfortunately, of course, does. So we have to put money into, because we talk about chronic disease, but before we get to that, we need to put money into prevention, and we need to incentivize people
Mhm,
in a
mhm.
sense from a prevention, of course, standpoint. So
Yeah.
that's where I feel, because like you said, chronic disease management, it is important. But what if we could get people prior to them getting these chronic diseases?
Mhm,
When we look at children's health, as you know, we're trying to work within the organization with programs, of course, for children. We've got to bring the parents along as well. But if we
mhm.
could focus again on this, prevention, we could, of course, hopefully, decrease or some of this chronic disease management. But I think that the messages are out there. There's no doubt that the messages are out there, but how are we going to, attack it? And I think definitely in these communities, we have to do a better job at attacking it. And a lot of that's going to mean being in these communities. And that's a
Mhm.
lot, we come into communities, we do, and you know how I feel about that. We do a little study and then we pull out and we
Yeah.
don't see nobody
Yeah.
anymore. We see you for a good
Yeah.
6 months, a year, and, I've said that when people have come to me about being a part of the program. I'm not about coming and putting on a show in a community. I'm really about how can you come to this community and how do we sustain the programs in this community, and we continue to help the people, of course, in these, of course, communities.
Right. And when we kind of have more of an empathetic look at things, I think whether diabetes or chronic conditions are our
Mhm.
personal problem, we
Yes.
may have other issues. And
Yes.
for most individuals, a quick crash course is not enough to
Yes.
motivate for a lifetime. Like we continuously need reminders, whatever our personal health goals might be.
Mhm.
You know, people need those continual reminders. So, we can't look at those individuals. Well, we did this program. I mean, didn't you get it? Yeah. And,
Absolutely.
and next year
Absolutely.
we'll need a check-in, and the year after we'll need that
Absolutely.
motivation and
Absolutely.
an update and things like that. Especially as
Yes.
technology changes. And
Oh, yes.
we
Oh,
just
yes.
had a conference, the Association for Diabetes Care and Education Specialists conference. The name
Yes.
changed, and I was struggling.
Yes.
Um, and they presented some awesome technologies and
Yes.
advances that are coming, but if people don't know about them, if they're not presented in the clinics or facilities where they go for care,
Yes.
then they will not be able to avail themselves of those services, even if they're there, even if they're available.
Absolutely, or have access to them. You know,
Mhm.
we're dealing with, of course, people that don't have technology. My husband is an educator, and you know, we're dealing with kids that don't have, you know, computers or, you know,
Mm,
tablets or something to access. And this is something that's very, very prevalent, of course, in these
mhm,
communities, and definitely people, communities of color. And I will not say that it does not happen in others, but of course, we know that it is, you know, of course, you know, more extensive, of course, in these communities. So
mhm,
you're absolutely, absolutely right.
mhm. And my colleague here, Adelaide, says prevention is better than cure. That is a
Yeah.
quote that my mother used to say.
Oh, yeah.
Interesting. She said it's a saying. She said it's a saying for a reason. It's so true.
Yes.
And the
Hmm.
exciting thing, I think, from what I understand in the UK, their GPs and practitioners are moving more towards what they call fee for what is it called? Not a fee for service, which is how we have it here, meaning they get
Yes.
paid for how many services they provide, and the
Yes.
more expensive the procedure, the more they get paid, kind of thing.
Yes.
Sometimes it can be like that here,
Hmm.
but in the UK, it seems like more so they're giving incentives for their outcomes. So
Okay.
the
Yes.
outcomes of their patient population, the more incentives they get for that. And I'm glad that many organizations are starting to move towards that, because that helps the patient feel like, okay, you're not here just to give me the most expensive drug or treatment or whatever it is, but you actually care
Absolutely.
that my numbers are improving. So,
Absolutely, absolutely. And
um,
working together, I often say, you know, with my patients, that whomever that you're with, that you're a team. I
mhm,
say to them that nobody knows their body better than you. So you need to work with a physician that is going to work with you, and whatever that, you know, path of another patient. Of course, just last week, she says, hey, they sent me this metformin. You know, she just kind of peaked over, of course, going with, I think, you know, a little bit higher than normal, of course, A1C. And she said to me, you know, I just want to do everything I can. Do I have to take this medication? And I said, as a nurse, I can't say do not take medication. But what I can say to you is go back to your physician and say, I'm
mhm,
signing up for this program. You work with me. Let's look at my numbers. I want to hold off on this medication till I do this program. And that's a partnership. So being able to have that type of conversation with your physician is so important. And knowing that they work for you, because that's somehow that it seems that it's reversed, but
that's true.
they work for you, and they can't treat you until they get information from you. So again, just again empowering them.
Mhm. And one thing that I want to make sure that our uh, Black Behavioral Health community is aware of is that there are programs that you may qualify for that may even be at no cost. So very
Yes.
similar to the program that Miss Lisa manages. Well, she has several, but the classes that she manages, the diabetes prevention programs, they have a diabetes prevention program in the UK. So
Yeah.
please
Oh, okay.
ask your GP if you
Mm-hmm.
qualify so that they can refer you. It does work on a referral basis. But you can
Mm-hmm.
also go to Diabetes UK. They have a little questionnaire that you can fill out about your risk. And based on the results, they can also put you in contact with the program in your area that you may be able to sign up for.
Mm-hmm.
So please go there. And that website has lots of other good information too. But I want to make sure that individuals are empowered themselves to find information, because you may not always hear it from the provider, that maybe they may not know about it, but you
Yes.
can come to them and say, hey, I heard about this program, do I qualify, etc. So
Mm-hmm.
definitely look into that. Now let's kind of talk about some of the kind of compare and contrast as far as the UK and the US a little bit. Now, in the UK, about 6% of individuals are diagnosed with diabetes. So
Mm-hmm.
In the US it's a little bit higher, but still 3.4 million people diagnosed. But of course, they estimate that it could be as much as 4.8 million people, because of course there are many who do not know that they are diabetic yet. And they have about 200,000 new cases diagnosed per year. And in addition to that, you also have about 5 million individuals who they estimate are at risk. So they have pre-diabetes. They've been told that they're at increased risk of developing diabetes. So when you put that together, that comes to almost 9 million people in the UK who not only need to hear this information, but their networks as well, their
Yes,
families,
absolutely.
their networks who need to hear this. So definitely, this is an area of concern. And in the U.S., those numbers are rising, especially in conjunction with our obesity rate. Can you talk
Yeah.
about that?
Yeah, and and it's interesting, as I said earlier, the thing that took me down the path is really, of course, these increasing numbers. And as you know, here, I think with our last 2020 CDC report, we had 34 million, of course, the diagnosed, and 88 million with prediabetes, or of course, and a large percentage of those people don't even know, of course, that they are, of course, at risk. We know definitely number one, and I always say to people, everybody who's overweight doesn't have diabetes, and everybody who's, not overweight does not have diabetes. But that is, of course, our greatest risk factor right now is, of course, people being overweight. So which of course calls the attention to us really, of course, putting more emphasis on looking at, of course, weight management. And I think, again, I cannot say enough, starting, of course, as children. This report actually did, of course, highlight in a sense that some of our children, of course, with the obesity rate, putting them or setting them up, of course, for the possibility of being, pre-diabetic and later diabetic. So looking at one of the programs, that we work with here, which is the CDC DPP program, that focuses on, of course, the biggest area that we're looking at is weight reduction. So looking at programs like that really can help people to lose weight, get a healthier relationship, because really it's about changing that behavior, a healthier relationship, of course, with food. And by doing that, being able to decrease, of course, their possibility of getting diabetes.
And of course, being that we are in a pandemic, I do have to touch on COVID a little bit, because we kept hearing on the news across the board that people with these comorbidities are more at risk of complications and things like that. But I want to even offer that as more of a motivation for individuals to go get screened, go get checked, because not so much, I don't want people to think of it as an inevitable outcome, like, man, I have diabetes and high blood pressure or whatever. That means that my odds of fighting this go down. But rather as a tool to say, okay, there's no vaccine for COVID yet. There's really no there's no official treatments for COVID yet. But what we can do, is just take care of ourselves and managing those other conditions along the way.
Absolutely.
Is that something that you kind of integrate with your patients throughout or that you've done in the past few months?
Yes. And I think that, what we want to be clear on, because the thought is, of course, I have, diabetes, I'm going to get COVID. And it really is looking at, as we do with people with chronic diseases across the board, the potential risk, in a sense, is when we're not managing, of course, that disease process well. So because of not managing that disease process well, that, of course, weakens the immune system and kind of invites the possibility for us to, potential, not just COVID, we're talking about flu and everything else. That's why, of course, they ask in regards to us getting vaccinated and all of that. So what I have said to them, and to your point, this is the time that we, again, take charge of our health, make sure that we are keeping these numbers under control, making sure that we're eating the right foods, of course, that contribute, or if we, if we supplements or something that need to be done to make sure we're building up our immune system. So I will say that just with having that is not saying that I will get COVID, or COVID, I'm going to, again, get this and may not be here. What it's saying is that we want to keep these, of course, whatever that disease, high blood pressure, like you said, diabetes, all of those things, keeping those things under control. And by doing that, I'm decreasing my risk of COVID and just decreasing my risk of either further, of course, complications by keeping those numbers under control.
Yes. Can you talk a little bit about what you've seen as being a practitioner for all of these years, as far as representation in the leadership positions as healthcare providers, and the benefit of that representation for our patient population?
I will say that we're still challenged, of course, in this area. I believe that, again, it is important for, in a sense, anyone who wants to help. And again, I'm here, and my goal is helping all people, and all people, of course, with diabetes. But I do believe that in some instances, it is important for people to see people that look like them. And whether it's the Spanish community, like I said, African American community, South Asian community, and there's a certain connection because of just life experiences. And I know sometimes with my senior patients, that is important, of course, to them. So I do believe that we do need, of course, like I said, all practitioners are here to help, but I do believe that we need more in the African American community, Latino community, South Asian community, the people, of course, that are here that look like them, where these messages, that are delivering, of course, these messages. And I don't think that we've gotten there yet.
Right.
As I said earlier, we have a lot of people that come into these communities and they take from the communities and never, of course, give back. So I would like to see us do a better job there. I don't think that we are there. I've been blessed in my position, but I'm kind of somewhat of a rebel. So sometimes, if they don't let me in, I might try to kick the door, of course, in.
Right.
But what I will say is that what I've done is that I've had to push a little bit. And oftentimes the only person there of color. And as many of us in this position, then the weight of all of this is on our shoulder to try to understand, or help them to understand what our plight of our community. So I do believe, and I don't believe that everybody has to come, because there's so many important other people that are behind the scenes, of course, pushing forward. But I do believe that we do need to see more physicians, nurses, doctors, educators, all of that, that are representations, and that people can see that, and that we are able to connect. As I said earlier with the man that I knew what a chapati was, but he, as again, him just thinking, hey, you don't know because you're not South Asian, but I make a point to know, and I make a point to know, of course, because these are the people that I serve. And that's something that I feel that if we are coming into the communities, you need to make a point to know, and knowing the community that you're serving, and not thinking we're looking at something that's a cookie cutter and it can work in all, of course, communities.
That's true. Well, I think we will kind of start wrapping it up here, and we've had so many excellent take-home points throughout the course of this presentation, but I do want to add and touch on what some of the numbers that we were talking about earlier. If you have diabetes, if you've already been diagnosed, just make sure that you're empowered in knowing your numbers. Sometimes we may not want to check, we don't want, it hurts, whatever the case is, to prick your finger, but make sure that you know your numbers, be empowered in that sense, and be an advocate for yourself, to your GP, as well as making sure that your family members advocate for you too. If you know, just it strengthens the presence when you do see your provider. So if you are currently diabetic, if you've already been diagnosed, your doctor may be looking for you to reach a goal, as we said, a goal A1C of about 7%, which correlates to about 8.6 for the UK. So that is the goal. For individuals who do not have diabetes but are at greater risk, your GP may tell you that you have numbers around 7 or 7.8 on the EAG, but make sure that you are tracking that, monitoring that. As you go for your regular checkups, make sure that they are also continuing to monitor that, and that you do your daily checks as well with your at-home device. So if there's any take home that you could leave with us as we wrap up today, what would you like to share with us?
Well, again, as I said earlier, I just want people to know that the power, of course, is in their hands. We
Mhm.
know how important prevention, of course, is. Definitely, as you said, knowing those numbers, diabetes numbers, cholesterol numbers, blood pressure numbers are so, of course, important. And knowing that this is something you can do something about. And most of these across the board. Again, some things we have, and it's a genetic predisposition, means that my mother had it, my father had it, and I probably may get that. But a lot of things are up to us. So I just want you, again, like I said, taking charge of you, and knowing that, of course, that you also can winning at diabetes, heart disease, all of those different things. And as Sarah said, connecting with educators in your area, physicians in your area. And sometimes you do have to push a little bit, because the saddest part is that sometimes they do not know. And we're dealing with that here in the US, and really trying to educate our providers in regards to how to deal with diabetes, of course, management. So just taking charge, and again, that you can do something about this. And the key is prevention. And one of the other things, exercise, food is medicine. So doing these things, of course, can help to heal the body. And I
Mhm.
want to just say I thank you, of course, for Sarah, Sarah, for having me on today. As I said at the top, one of my favorite, of course, people. Just so excited, of course, the work that we've done together, and that we will, of course, do together in the future. And definitely out, of course, across the waters. This is so exciting to speak to all of you. But again, like I said, that you can, of course, win. And just knowing the power, again, is in your hands. And I don't want to make it seem too easy, but connecting with individuals like here, your organization here, the Beta organization, and other organizations within your area, to help and provide with resources and just support. You do not have to do it, of course, alone.
So please let us know your Instagram so people can go and see all of the good information that you have there that applies to everyone, and that they can contact you in the future.
Yeah, so Diabetes You Can Win, at Diabetes You Can Win. You can also find us online at diabetesYouCanWin.org, and then also on Facebook at Diabetes You Can Win. And you can come out there and see, of course, Sarah and the wonderful work that she's doing in these support groups, and
Hmm.
just get daily motivation, because we have some great groups there, and she's doing an excellent job with, of course, just keeping you motivated throughout the week. I'm so excited, and I just feel so, as I tell them all the time, so blessed to just have such talented, of course, individuals. So you like seeing Sarah here, you can follow her, of course, on Facebook, and
Oh
it's,
boy,
again,
we're here to
at the
talk about you.
You Can Win support group. You are winning with diabetes, and then you are winning diabetes prevention, and then, of course, that you can win with
Yes,
support group. So
and that's diabetes underscore you can win on Instagram, right?
yes, diabetes underscore. I'm sorry, You Can Win on. So I'm one of those, of course. I have wonderful people around me with this technology. So again, there's a great save, definitely, at diabetes underscore You Can Win.
No
Thank you,
problem.
thank you.
Yes, and thank you for everyone who has tuned in today and who's going to watch it later.
Yeah.
Please share with other individuals who might benefit. Again, you can always go to blackbeetlehealth.co.uk in order to see all of the organizations that we signpost to, including Diabetes UK. Please follow us, sign up for our email list, and stay in touch with other events that we have coming up. All right. Thank you
Yeah.
all. Have a
Thank
great
you.
evening.
Have a good one. Bye bye.